Well, the whole issue surrounding metabolic complications in kidney transplant patients really revolves around what I call the holy trinity of risk for cardiovascular events, and that is blood pressure, cholesterol, and glucose, and how best to manage that in the kidney transplant patient. Most people tend to forget that the leading cause of long-term kidney transplant failure is cardiovascular events. So a major focus should be on the relationship between reduced renal function, immunosuppression, and risk for stroke and heart attack. The major questions and the debate and the questions that I am sure will ensue will be, what are the best medicines to lower blood pressure? What's the right goal? How low should you go? You could ask the same question about dealing with glycemic control. What's the best long-term measure? Is it hemoglobin A1C? Are there preferred therapeutic strategies for immunosuppression in people who have diabetes or who are at risk for diabetes? And are there, better medication strategies? How good is metformin in these types of patients? And then many questions arise about the newer SGLT2 inhibitors, the GLP-1 agonists, which now are showing some benefit on cardiovascular outcome. Should they not be used more frequently in our kidney transplant population who are at risk? Again, some of these drugs actually can be used quite effectively in people with lower measured GFR. And then lastly, the whole issue of cholesterol, cardiovascular protection. Should everybody be on an antiplatelet therapy? Should everybody be on a statin? If so, which one? What's the target? Is there a target? Or as in the National Cholesterol Education Program recommendations, should it just be a 40% reduction in LDL from baseline in high-risk populations? So there's much to discuss, much to discover, and a lot of need for big answers moving forward. Well, calcineurin inhibitors remain the treatment of major importance for us. Yes, there are some potential alternative strategies. The biological belatacept, some have suggested that mTOR inhibitors may be a suitable suggestion. I think that remains to be seen on a broad scale. Certainly that's an opportunity. I would say, quite honestly, it is rare for me to need to change a calcineurin inhibitor because I am concerned about its metabolic complications. I think there is more than sufficient opportunity to use both behavioral modification and different types of therapeutic strategies in these individuals. I can't recall the last time I had to take a person off or reduce the dose of a calcineurin inhibitor simply because I felt I could not gain control of their metabolic complications. Certainly side effects is another issue, and if patients are having CNI-specific adverse events, then you may need to switch to another one or to an mTOR or to belatacept, absolutely, but not for metabolic issues. I think we have enough tools in our armamentarium that we can deal with the risk in that sense. Yeah, I'm very excited about the newer strategies for treating diabetes. I've been involved in a number of the clinical trials. I'm actually going to be going from here down to the American Diabetes Association meetings because we're part of a report that's coming out tomorrow on a new strategy to reduce cardiovascular events in people with diabetes with a newer drug. There are now several classes which I think have risen to the top of our understanding. Certainly the age-old metformin remains an important mainstay. The real question would be what's best to add to metformin. Again, the SGLT2 inhibitors and the GLP-1 agonists are what are most exciting right now. There is new data coming out on empagliflozin that's being presented tomorrow. The LEADER study is coming out as well with a GLP-1 agonist. So there's a lot of excitement now in the community. Now, of course, the question is, knowing with certainty, are there any potential drug-drug interactions with many of the medicines we use in our patients for kidney transplants. And of course, also the question too is the utility of these agents even in people with lower GFR. From what I've seen in most of the data so far, if your GFR is above 30, it's wide open to use many of these newer drugs. They may not be as efficacious in actually reducing hemoglobin A1C, but for reasons that we're still learning about, we see reductions in blood pressure. There may be pressure-volume control relationships which are important for the heart that we still need to sort out. There could be effects on vascular compliance, which could be a nice opportunity to learn more. So I think there's much room for improvement. The whole issue of CNI and long-term renal function, I think many of us are re-examining the data. I think certainly we appreciate CNI have a reversible or functional vasoconstrictive effect on GFR. So if you stop a CNI on a patient, you're going to see a 10 to 15% improvement in the GFR. Now, whether or not that translates into a long-term effect, we just don't know. I think the practical issue is decisions about immunosuppression have to be very, very carefully individualized. I don't disagree that in Spare the Nephron, we saw immediate changes in GFR when removing CNI. And again, largely that is related to removal of the vasoconstrictive effect. We have no reason to believe that vasoconstriction truly leads to a long-term renal injury. It may be just a functional effect. If anything, some have theorized that if there is a hyperfiltration renal injury, conceivably it could even be protective from that standpoint. But I am not at all surprised that long-term they're very similar measures of kidney function. You could raise the same argument with belatacept. Again, there's no vasoconstrictive influence. Short-term changes in GFR, are they going to translate into long-term changes? Well, you don't know until you take the patient off the drug after 3 or 4 years, and then if the GFR bounces right back up to be therapeutically, or measurably the same as a CNI removal, whether it's an mTOR or a belatacept, again, is that a harmful concern? Is that something that translates into a better long-term outcome? I'm not sure we really know yet. Well, those are really two separate questions, even though they're very carefully intertwined. The major concern now is no longer acute cellular rejection. I think if we see that late, it is more a sign of non-compliance among the patient or maybe overzealous winnowing of immunosuppression. I think our major concern is the long-term development of donor-specific antibody and low-grade, smoldering, chronic antibody-mediated rejection, which often results in a proteinuric nephropathy and then the slow loss of kidney function over time. That really, I think, is a much more important concern for us, both to recognize early and then ultimately to develop a therapeutic strategy to prevent it. It raises questions for me about wild changes in immunosuppression unless they're really indicated more by toxicity than anything else. It may very well be that having slightly higher doses of overall immunosuppression for a longer period of time, as long as it is well tolerated by the individual, may in fact be a safer and more effective strategy for limiting the likelihood of the development of chronic antibody-mediated rejection. That may explain, again, some of the long-term differences between better matched grafts versus lesser matched grafts. For me, I always believe in the theory that if it's working well, don't mess around with it. So I think as we try to strategize to improve overall renal function, we have to be careful. And that for some patients, there are preferred strategies. Maybe it is withdrawing a CNI. Maybe it is switching to an mTOR or a belatacept. But I think long term, the real focus is individualizing immunosuppression therapy in a safe and effective way to be sure that we don't develop DSA, to be sure we can better prophylax against the development of chronic antibody-mediated rejection. Well, I think some of the key discussions so far are primarily related to the new kidney allocation system. Again, I tend to be more nephrocentric. There's a lot of very interesting data in liver as well, and whether or not you should get a kidney with a liver or just a liver alone, followed by a kidney later if need be. There are many practical issues depending upon your interest and focus. The ATC is now much more than a kidney or kidney-pancreas meeting. It spans all of the organs. There have been fascinating sessions on thymus transplantation, which may lead to better means of tolerance induction later on. I think there are a lot of nice and novel and interesting ideas about stimulating tolerance through T regulatory cell pathways. I mean, it's an evolving science, and ultimately we hope to have unique and individualized ways of performing immunosuppression without obviously broad-scale immunodepression, which is what we've done historically.